Hi, and welcome to another edition of the Cancer Now What vodcast. I'm so glad that you're joining us today. My name is Jenny Martin, and I'm joined in studio by three physicians who are very well versed in the lung cancer disease. We have Dr. Justin Famoso with Arizona Center for Cancer Care, Dr. Rohan Sharma with Virginia G. Piper Cancer Care Network and Arizona Center for Cancer Care, and Dr. Richard Gillespie with HonorHealth. Thank you all so much for being here. I really appreciate you taking the time.
Yeah, thanks for having us.
Of course, of course.
Always a pleasure.
Good. Thank you, Dr. Gillespie. So I thought I'd really quickly just introduce you all to the audience and speak a little bit about your specialty first, because as our audience knows, cancer care is a very complicated, multidisciplinary field, and it takes a village, if you will, and you are all a very integral part of that village when it comes to treating lung cancer. So Dr. Gillespie, cardiothoracic surgery, correct?
That's correct.
Okay, so what is your role in this cancer journey, and what is your part in treating cancer?
I'm a cardiothoracic surgeon by training, which is pretty broad, but I'm sort of a subset of our field. I'm a thoracic surgical oncologist, so I really focus on operations that involve lung cancer, esophageal cancer, procedures that are needed for either diagnostic purposes or for the removal of cancer. And a lot of what we focus on is minimally invasive treatments for the disease.
Great. Thank you. That helps. Dr. Sharma, as the medical oncologist of the group, what are your focuses when it comes to treating cancer patients?
So in regards to lung cancer, my main role is the medical management of cancer. So the areas where I tend to play the biggest role are in the metastatic stage 4 kind of setting. Things like chemotherapy, targeted treatments in that setting. And also the adjuvant setting, in other words, treatments that are designed to help prevent cancer from coming back, or treatments that are given after radiation or surgery. And lastly, surveillance or survivorship for folks who are cured, and we're trying to prevent cancer from coming back.
Great. Awesome. Also very important job.
Yeah, I'd say so.
And Dr. Famoso, radiation oncology.
Right.
So help our audience understand a little bit about your role in the lung cancer journey.
Right. So I'm a radiation oncologist, and what that means is I kill cancer with X-rays. So a lot of people don't really have a full understanding of what radiation is because, none of us are really born with this knowledge, but radiation is not as scary as what you'd see on TV or in the movies. Nobody's glowing in the dark. It's just X-rays. So with that in mind, you can think of a radiation oncologist's job as targeting cancer that can be a problem, whether that's in the early stage lung cancer or in the late stage of a metastatic lung cancer, like Dr. Sharma had talked about. I target those areas that are problems and try to, kill cancer with X-rays.
Very cool.
Yeah.
Very cool. So now all three of you play very different yet very important roles. But let's go back to when a patient first has symptoms. What Dr. Sharma, I'll ask you, is the typical symptom? How do you know if it's time to worry about lung cancer?
So I would say that usually the primary care doctor or the ER physician is most alerted to those initial symptoms, which can vary quite a bit. Subtle chest pain, shortness of breath, coughing up of blood, which obviously will bring someone to the attention of a doctor very quickly. But unintentional weight loss. These symptoms can vary quite widely, or a cough that just simply won't go away. And the typical story is that someone has these kind of concerning symptoms, which prompts, a primary care or an ER physician to get a chest X-ray or even a CAT scan of the chest. And then, a radiologist will notice something that's abnormal, which one thing will lead to another. Eventually, a pulmonologist will get involved. And it's usually at that stage that I get involved, because I found that and I think most primary care doctors would agree, that it's it's good to get an oncologist involved earlier rather than later. We can help direct the staging of the cancer and think of things that maybe aren't immediately obvious as we're trying to obtain what ultimately is needed is a tissue biopsy to confirm exactly what's going on.
Okay, that sounds good.
Yeah, actually, I jump in, Dr. Sharma, because as we all know, most of the time when we're catching lung cancer, especially early, it's asymptomatic. A lot of the things that we, when people have symptoms, it's often a sign that there's actually more advanced disease. So, it's not uncommon for people to have nodules picked up on x-rays that they're getting for different reasons. You go in for because you've got abdominal pain to the ER and they catch a nodule on the lung fields and it's an incidental finding. So, in a lot of ways, and I do think, pulmonology certainly does play a role, but when you identify something even without symptoms, it has to be worked up. And, when we do that appropriately, we're able to catch things earlier.
Yeah, that's a really good point. So if I'm just a, non-smoker human in the world, right? There's no way for me to know that I might have a lung cancer growing. Like what, without needing going to the ER for some other reason. Like what can people do in terms of screenings or prevention to mitigate that risk, right? That we're talking about here, because, if it's asymptomatic, how are you supposed to make sure you don't get it?
Don't smoke.
Okay.
Let's get started.
Yes.
with that.
Okay.
Love
good
it.
advice. I've
So-
heard that one before.
Yeah, no
Dad.
doubt. So,
okay.
yeah, well, your dad was right.
Yes, he's also a physician, so that's probably
But
why.
the thing about it is that there are patients that are non-smokers that get lung cancer. That is absolutely true. I'd say probably 1 in 10 of the patients that I take care of are, but that's still a fairly low risk. And so I don't think people need to walk around worrying that they've got lung cancer brewing in them any more than people really, worry about colon cancer, worry about, other things. Yes, there's a risk being a human being walking the earth. Fact. But, people who are high risk, if they're appropriately screened, that's a good thing. But for those of us who choose not to have, to bring in big risk factors, I think that you can feel like that's, that it's going to be okay.
Yeah, there are currently guidelines for low-dose CT screening, something the primary care doctors are especially aware of. Folks who smoke are active smokers who have quit smoking within 15 years of being 55 to 74 years old, I believe. There's data to support doing annual low-dose CT scans to pick up nodules. Dr. Gillespie is completely right about smoking. I mean, I think it's well established. Most people do recognize this as a significant risk factor. I believe the relative risk is about 13 if you're a smoker in terms of getting lung cancer. In other words, someone who's a smoker is 13 times more likely to develop lung cancer than a non-smoker. So it's all about risk, ultimately. Right. There are certain subsets of individuals who are non-smokers who are more prone to getting lung cancer, particularly women in their 40 to 50-year-old range who are non-smokers and of Asian descent. That's something that is definitely a known entity. But as of right now, I'm not aware of any screening protocol for those individuals.
Okay. Yeah. Anything to add?
I think it's just important to remember, especially for the viewers out there, that as with cancer, with any cancer, especially lung cancer included, the key to beating it is finding it early. So if you're a smoker, or even if you were a smoker, within the past 15 years, right? Smoking kind of went out of popularity recently. But if you think of people who were smoking in the 80s and 90s, that was just something they had done their whole life, and it was a normal thing to do in society at that point. Those people are at risk for a lung cancer, and they would fit the criteria of needing screened. So if you are over the age of 50, if you have smoked, there's a pack year calculation, which is kind of probably above the level of this conversation. But if you're a smoker and you've smoked within the past 15 years, get screened. The earlier you catch it, the better odds we have of curing it.
Yeah, we talk about this. Advanced stage cancer, we see probably 80% of the patients that come through the door. And these are the ones that are symptomatic, like you talked about. And so only 20% of the people that we see are stage 1, stage 2, early stage. And those are the folks that we have the best chance at achieving cure. And so the big fight that we are, really working on right now, and there's a lot of things out there work being done, but moving the needle, bringing those stage 3 and 4 patients into the stage 1 and 2, because the only difference between them is, a year, right? And so if you can catch them a year earlier, you're making a difference. And that all comes down to good screening protocols.
That's really good information. So immediately in my mind, I'm thinking about what you said, Dr. Famoso, about, smoking not being as normalized as it was back in the day. But what about vaping?
Man, I might let somebody else take that.
Because I know that my kids are going to high school and they're seeing it in the bathrooms, and it's the new normal, right? So I know that we have very hard data around nicotine and inhaling tobacco, but it can't be good to put any kind of chemical into your lungs, right? I mean, I didn't go to medical school, but that just feels like it's on par with cigarettes.
Yeah. I don't know if we know how it compares with cigarette smoking, but you're absolutely right. I mean, anything that that's noxious, that's going into your lungs cannot be good for it, and you should probably not do it. Yeah.
Yeah, we don't even really know what's in that stuff, right? So it's like, tobacco is regulated, and all vaping products are not. Like, you really don't know. It could be cyanide. You have no idea.
You just don't know. No clue. It's just, okay. So probably best to just not do either if you don't want to get lung cancer.
But the flavors are sweet.
That's the problem. It's too good.
That's the problem. Exactly. All right. So now we know how to prevent lung cancer. We know what to do, how to get screened early. So let's say somebody gets a diagnosis of lung cancer and they make it first to the medical oncologist. What is the first thing that you're going to do? Is that when the staging happens?
Yeah, the first step is always staging a cancer. That's true of any cancer in general, because that dictates the treatment plan ultimately. So what folks can expect is that I'm going to be, the first thing is always counseling someone, just acknowledging what's going on and just letting them know that we're here to help. I think that's the first step of any interaction. And in terms of staging, oftentimes, if someone doesn't have a tissue biopsy, I will work on arranging that. I will order a PET scan, which is a specialized scan to localize cancer wherever it may be in the body. Very oftentimes, I will ask someone about if they have any kind of headaches or visual changes, things that are concerning for maybe cancer involvement of the brain, which is something that's prone to happen with lung cancers in general, which may prompt me to get an MRI of the brain. Just kind of basic labs as well, just to see if that points me in one direction or another. And very early, I will get my colleagues involved, the thoracic surgeon like Dr. Gillespie, the radiation doctor like Dr. Famoso. We're in regular contact with each other. We often attend tumor boards together to kind of emphasize a multidisciplinary approach to treating a patient.
Okay, so you'll have conversations with them before you even know if they need surgery or radiation?
Oh yeah, 100%. I mean, it's important to get colleagues involved. We always operate as a team, because oftentimes we'll fill in the gaps for each other. I don't pretend to know everything, and that's where I really rely on the surgeon and the radiation doctors to kind of point out things that maybe I missed.
Okay.
So that's the whole point of having that you don't get into oncology or cancer because you're a lone wolf kind of mentality. You enjoy working as a team, and it's better for patients ultimately.
Okay.
Yeah.
So now you're looking at the scans, and Dr. Gillespie is looking at the scans, and Dr. Famoso is looking at the scans, and then the three of you come up with a treatment plan to deliver to the patient and their family. Is that what that looks like?
Yeah, I would say that's kind of how it looks like.
Okay.
And then we present the options for the patient and the family. And then, I kind of describe myself as being in an advisory role. I like to kind of lay out the options for patients, and I think it's better for patients. They feel like they're more invested in their treatment plan.
Okay.
The more invested they are, the more likely they are to benefit from it.
So is it And I know cancer is not typical and every human is different, right? And the way that they need to be treated through their journey. But is it usually the case that they'll have surgery first or chemo first or radiation first? How do you make that decision?
I would say that comes back to the staging. Generally speaking, surgery is preferred where it's indicated and it has a high likelihood of working to eradicate the cancer. So that's more an option in earlier stages of cancer. When we're getting into more kind of later stages of cancer, and I would say, folks like, surgeons like Dr. Gillespie are very apt to know when surgery is likely to be successful and when someone is a good candidate for it based on their functional status and how healthy someone is versus maybe an alternative approach like radiation may be indicated if it's a localized cancer and has a very good chance of working as well. As we're getting into more advanced stages of cancer, my role kind of expands a bit more. Then we're talking more about things like chemotherapy, sometimes chemotherapy paired with radiation, which can also be potentially curable. And when we're getting to later stages where surgery is not possible or radiation is not possible, then we're talking more about kind of systemic treatments that go throughout the body, like chemotherapy. And oftentimes in those situations, we do special testing to see if someone is a candidate for more targeted treatments, like pills, for instance, or immunotherapy, and spare them the toxicity of traditional chemotherapy.
That makes sense. Thank you.
Yeah.
So, Dr. Gillespie, what makes someone a candidate for surgery?
If they come to a surgeon's office.
Spoken like a true surgeon.
Spoken like a true surgeon.
So I'll say this about lung cancer, and I think you guys would agree. What's really interesting about lung cancer now is that there's so much developing and changing, and for a long time, there were not a lot of developments. Doublet therapy was like the 70s. Most people got an operation, and that was really the only thing that was really available, or they were just not a candidate for treatment at all. And that was true really until maybe even 20 years ago. Things have changed now. So what we know about lung cancer is that if you catch it early, you can treat it early. So we talk about stage 1 and stage 2 candidates. Those are people who, if they're in good health, are candidates for an operation, followed typically by additional treatment if necessary. Those who are stage 3 and 4 were sometimes involved in the diagnostics, but surgery is not shown to give a benefit, and we look for different kinds of treatment plans.
Okay, that makes sense. So not everybody.
Not
needs
everybody.
surgery.
Not everybody.
Okay, we're going to quote them. And then what about radiation? When is it time? What makes them a good candidate for radiation treatment?
Yeah, I like to think of radiation as kind of like surgery's backup. We're kind of like the pinch hitter where, if surgery can't be achieved for whatever reason, whether it's a patient who does not have good lung function and can't tolerate a removal of a piece of their lung, or if the tumor is, too big or wrapped around something that can't be taken out, or if the tumor has already spread to some lymph nodes that are further up in the chest that, can't be taken out with surgery, then radiation starts to play a role. So a lot of times with lung cancer, you're thinking of do something to the tumor, whether it's take it out or give it radiation, and then some form of chemotherapy afterward if there's a risk of the cancer having spread. Right. So you can think of the do something to the tumor as surgery first if possible, and then if not possible, radiation's kind of plan 1B, So radiation fits kind of interdigitated, not necessarily in conflict with any of these other treatments.
In combination.
Yeah.
And there are lots of tools in the toolbox.
Right.
Right. And so every patient is different. Every patient has to be individually assessed, and you pick from the menu, what treatment plan is best for them. And one of the things that's interesting about lung cancer is that the plans can be radically different depending on what the patient is bringing. And, there's opportunities for all of us to play a role that's really helpful.
Yeah.
So Do you guys ever get into fights over who's right and whose turn it is? And like, how do you, like, I mean, I can imagine like what happens in these tumor boards, right? If there's lots and lots of doctors in there and there's difference of opinions, how do you navigate that?
I actually think people are really respectful.
Yeah, I was going to say, we've never fought
Oh my
once.
gosh.
I think things are
That's amazing.
pretty cordial.
Yeah.
For the most part.
Well, you know, when
All
you,
right,
when you have a
tumor board
bunch
in
of...
my mind, it's very different than in reality, apparently.
I mean, you get a
So-
bunch of professionals in the room who are all really well educated and are at the top of their field. We all know pretty much within reason what the other one is thinking. And if Dr. Gillespie gives me a look like, I don't know if this thing can come out, well, then you know, okay, well, then this is my time to
This is
shine.
your
And if
turn,
I look
right.
at something and say,
Honestly, often we're grateful. Like
Yeah.
there's stuff that I look at that I'm like, I can't do anything with this. Can you help this person? You
Right.
know, or, you know, we have somebody with an undiagnosed nodule, you know, and they'll come to me, we've tried to get a biopsy, but we can't. You know, how do we achieve this? So we actually pick each other's brains
Amazing.
and ask questions way more than we say, you have to do it this way.
Or I've got this.
You know, so, well, I don't know. There's a little I got this. But that's, you know, that's the thing. I mean, this is a team-based sport. Like,
Right.
there's no question about
That's
it.
amazing. So how do you keep in touch with each other when you've made this decision about what to do with this patient? Do you text each other? Do you call each other? I mean, you're not all in the same office, right? So how do you keep it a team sport if you're not all on the same field, as it were?
Yeah, I think we are staying regular contact with each other. We try to call each other about patients. You know, I'm pretty much, you know, always on my phone. So if you text me or call me, I'll pretty much respond right away. I think, you know, both my colleagues here could attest to that. But yeah, it can be a challenge, especially with COVID. We do these tumor boards more or less virtually for the most part. You know, no one, I think, has their ego completely invested in this. We're willing to concede that maybe, you know, I may know more about one thing versus another, versus, you know, Dr. Gillespie will know more about something than I will. And that ultimately guides us to what is the appropriate treatment plan. So it's all about communication, you know, and we have many avenues to achieve that.
That's great. That's great to hear.
I mean, I just tell my patients I'm connected at the hip with these guys. Like literally, like on my hip right now is a HIPAA compliant text thread full of, hey, what do you think about this? What are you going to do about this patient? And like, what's my strategy? What's our plan? And it's all day long, and it's behind the scenes. So patients may not realize it, but we are, you know, basically talking behind the scenes constantly.
Well, and that's everything, right? And I think it's really important too for our audience to understand that that is what's going on behind the scenes, because while the patient might be sitting in front of you not knowing that you're talking to each other, you definitely are. And it's important for them to realize that it's not in a silo.
You're not going to a doctor. You're going to a community.
Yeah.
That's huge.
And we, you know, it's to say that we talk constantly, I think is not, I mean, that's not far-fetched at all. I mean, I think I probably have 20 conversations a day with different specialists about patients, and that's not an exaggeration.
That's amazing. That's so important for sure. So let's shift gears a little bit, and I know Dr. Gillespie, you started talking about this, so I'll let you start. Changes and advances in lung cancer treatment. What's new and exciting in the last few years, and what's on the horizon?
Yeah, actually, so I think each of us is going to have something to say about this, because in all of our disciplines, there has been, within the past 5 to 10 years, some shifts that I think have made a real difference in what we can do. So, you know, just speaking on the surgical side, because, you know, I want you guys to get a chance to talk about your stuff. You know, one of the things that we really insist upon is minimally invasive operations. And currently, you know, the real standard right now is robotic surgery for lung cancer. And so, you know, in the old days, you know, a thoracotomy incision was normal, and that's just a big, you know, big, you know, cracking the chest, this kind of thing to get cancers out. Nowadays, we're making most of our incisions that are 8 to 12 millimeters in size, able to do the entire operation with just a few ports, and you know, a person has an operation, they recover in the hospital for, you know, 2 days as opposed to 7, and they're home doing pretty well after that. And so that advancement for us has been a really big deal. So
Okay, so I'm going to ask you this because I don't get to meet a lot of robotic surgeons. And a lot of people don't really know what that means. I mean, they're thinking, the housekeeper from the Jetsons is rolling over to the bed. And how does robotic surgery work? It's still your hands
Right, so-
doing the
Right.
manipulation.
yeah, it's funny. So we call it robotic because there's something between the physician and the patient that has some computerized component to it. It's not autonomous. It's not like you wind it up and you say, okay, go take out the cancer. A robotic surgery, so there's really only one company that does it, but there will be others in the future. But, there is a manufacturer, and these things exist in like pretty much every health system now. But what it is that you take a patient and you take the robot, which is a big thing that looks like kind of like a big tree with a few different arms, and you bring it over to the person, and you will dock the robotic arms to different ports that you then use to get into a human being. And once you do that, you have different instruments that you can then put in and do the operation on the inside. Now, the surgeon does not stand at the patient's bedside doing the operation with their hands there anymore. They sit over there at a video game console, and you have controls just like you have for like an Xbox, and you're watching the video screen and you're doing the operation that way, and the robot is doing what your hands are doing.
Wow.
So if you're doing this, it's doing this. If you're doing this, it's doing this. And that allows you to really do fine work, very delicate stuff through these tiny incisions. And so this is something that was developed over multiple years. Originally the robots were developed for the purpose of having a battlefield surgeon. So like you could bring the robot out to injured soldiers, and then the surgeons would be 2 miles away.
They'd be safe.
That was the plan. It never really panned out, but that's where the birth of the idea came, and that's how it works now.
Very cool. Very cool.
Yeah.
And what about in the medical oncology world? What's new and exciting in terms of treatment? I mean, the robot sounds kind of tough to beat, but you can give it a shot.
I don't know if I can top the robot.
Oh man, immunotherapy is pretty great.
Immunotherapy is pretty cool. Yes.
Things have been moving at light speed, really. I'm relatively new in my career, so I don't really know a time before where we were just exclusively using traditional chemotherapy. But basically, the way I try to explain it to patients is that with stage 4 lung cancer primarily, we're talking about 3 main buckets of treatment options. Number 1 are kind of pill-targeted options. And what's kind of standard now is to do molecular testing to determine if people have mutations or that make them eligible for pill-type option treatments, or for the second bucket, which is immunotherapy, which has really just revolutionized the treatment of lung cancer. So, to be able to treat lung cancer, if people are a candidate for it with just a pill, they take it home, is a potential game changer. It's not that it's 100% side effect free. Everything has potential side effects, but generally speaking, to not have to come into a chemo infusion suite and get chemotherapy through a port and just be at home and take a pill is, I think most would sign up for the latter. Mm-hmm. So that's really great. Immunotherapy, I'm sure people have seen commercials for Keytruda and Opdivo. That's been well established for over a decade now, since the canonical trials in melanoma, and that's been proven to people who are a candidate for it are living years potentially while they're on immunotherapy because of those robust kind of responses that people can get.
Can you explain immunotherapy, just kind of a bird's eye view of how it works? Because chemo, we know, is basically killing all healthy cells and all bad cells, right? Or
right.
Most. How does it's not...
It's more of a blunt hammer. Yeah,
okay, explain
like
this. Explain this, because I get questions about this all the time.
Sure, certainly. The way I explain immunotherapy is that you are harnessing your own immune system to attack the cancer. And this is a more kind of subtle, targeted approach rather than the blunt instrument, which is chemotherapy. And it's not like it's side effect free. Certainly people can get side effects, but to come in just once every few weeks and get a 30-minute infusion is really a game changer compared to how it used to be. That approach has proven to be very beneficial not only for lung cancer, but many other types of cancers. And like I said, the advantage is that although it can take a while for people to get a response, those subset of people that do get a very robust, long response can potentially live for years, which is amazing. We're never going to get completely away from traditional chemotherapy. So the third bucket is traditional chemo, which though is often paired with immunotherapy. So pretty much everyone, unless they're getting a targeted pill option, is getting some degree of immunotherapy because it's shown to have benefit beyond just traditional chemotherapy. We're not even talking about clinical trials, which Virginia G. Piper is very, active in, and a number of my colleagues are. So the number of options have really exploded in the past decade, and they just keep getting, that bucket keeps expanding and expanding. So.
Oh, that's very cool. So we've got a robot. We've got lots of different options to kill this cancer. And
yeah, it's funny because I actually heard Dr. Gillespie talking about how computers revolutionized surgery, and I kind of see some parallels in how computers revolutionized radiation treatments. Back in the day, which is actually not that long ago, the machines that delivered radiation were pretty, bare bones compared to what we have now. And our limitations to deliver pinpoint targeted radiation treatments were really limited by just the rudimentary nature of the machines themselves. And then, starting around the 80s or 90s, as the computers started getting better and as our robotics started getting better, then our ability to deliver a pinpoint laser-like beam of X-rays to a certain part of the body really exponentially exploded. So we could now target a small, blueberry-sized tumor in the middle of a body and hit it with a 0.5 millimeter accuracy. And if you think of what we're doing now compared to just 10 years ago, computers have just revolutionized radiation entirely. And that progression is only going to continue to advance. What we're seeing now is the ability to actually target a lung tumor as it moves. So you don't really feel this as we're breathing, but your lungs are always going up and down, and everything inside of it is actually going up and down also. So you could think of a little tumor in the lung is also going up and down to some degree, whether it's 5 millimeters or a centimeter or even more. And in the past, we just kind of said, well, the tumor's somewhere in here, treat that area. But now as our robotics get better, as our computer gets better, we can actually pinpoint the tumor as it moves through the respiratory cycle. So, X-rays haven't changed since the dawn of time, but our ability to deliver those X-rays to a smaller area, limiting side effects, shortening the course of radiation, that's the progression that we're seeing on our side of the lung cancer and any cancer coin.
that's very cool.
Yeah.
So it sounds like there is hope for a lot of people, that we can treat them and hopefully even cure people and prevent cancer, lung cancer specifically, if we follow suggestions from you guys and keep learning about this stuff. So I really appreciate you taking the time to explain all of that to us.
Yeah.
So I always want to end with a final thought for our audience. So I'll start with you, Dr. Gillespie. What do you want people to know about lung cancer?
That it's treatable. I think a lot of my patients come in and it looks like they've been, they're about to get knocked over by a stiff wind, and it's because they think that lung cancer is a death sentence. It's not. Lung cancers, early stage especially, are very treatable. Even advanced stage cancers, especially with some of the new advances in chemotherapy, are very treatable. And you just got to get to the right people, to the right experts, and, to get a plan together. So it's important. And, if you're a smoker, get screened. I would say that too.
Great. Thank you. That's great advice. Dr. Sharma, what do you want people to know about lung cancer?
I would echo that sentiment. I think it's a very exciting time for lung cancer. We're fortunate to have all these tools at our disposal. even in a stage 4 setting, we have many options available for patients. We're here to help. We're here to counsel families. And I think right here in Phoenix, Scottsdale area, we are fortunate to have so many great options for treatment, so many great specialists who are very invested in making sure that folks get the best possible outcome.
Definitely. Thank you. And Dr. Famoso, what do you want people to know and remember about lung cancer?
Yeah, I mean, it's really been covered by both the other doctors here. They've really said it well. But I just echo that, there's no time like tomorrow to have lung cancer. Honestly, it's every day that passes, there's something new. And, every day that a person, can make it through a treatment of lung cancer or get screened and find a lung cancer, the future really does hold a lot of promise. So all hope is not lost. This is something very treatable, something that we can really manage, and going forward, there's a lot of hope, and I'm optimistic.
Great. Thank you. And thank you all for being here today and talking with me about this and for our audience. So thank you, Dr. Gillespie, Dr. Famoso, and Dr. Sharma for sharing your time with us today. If you'd like more information on Dr. Sharma or Dr. Famoso, you can go to arizonaccc.com. If you'd like more information on Dr. Gillespie, you can go to honorhealth.com/cancer.